My name is Tamas Gal. I am Director of Research Informatics for Cancer Center, and we are going to talk today about cancer informatics. I guess in the context of bioinformatics and genomics and all that. Please, let's make this interactive. So if you have any questions, just interrupt. I think we have enough time. I only have about 17 slides, a couple of websites and videos, so I think we're going to get through no problem. Bill is watching the chat, so for people who are online, if you have questions, please post it in the chat, and then Bill is going to tell me. Okay. So we're going to talk about mostly precision medicine today because it's very relevant in cancer, especially in connection with bioinformatics and genomics. Going to list a couple of major applications of mostly precision medicine, some examples, and then at the end we're going to talk about real-world evidence, which is kind of a big new thing at NIH, how they want to conduct clinical trials. Okay, so what is precision medicine? What's the definition of precision medicine? I don't know how long you guys been in this field or interested. A couple of years ago, maybe 4, 5, 6 years ago, when this whole thing started to kind of formulate, people were talking about all kinds of things around looking at genomics and patient data, and then customize treatments based on that. A lot of times they brought up the term personalized medicine and a couple of others, but at the end they landed on precision medicine. So let's say that's why we call this kind of treatment options precision medicine. So the actual definition is tailoring of medical treatment to the individual characteristics of each patient. So it doesn't necessarily mean that we're trying to create specific drugs to each individual patient. It's more, though that's happening as well, but it's more around trying to drill down on the specific characteristics of the disease of a patient, so we can pick the right treatment for that specific disease. So you probably heard this, that cancer it's really not what we've been talking about, the big groups of cancer, breast cancer and lung cancer and these big disease types, but more like triple negative breast cancer, where you drill down on the details of a disease, or EGFR positive lung cancer, or so a lot of smaller groups, and actually the treatment and the behavior of these specific disease groups, even inside, let's say, breast cancer, is very different. So what we're trying to do is kind of creating subpopulations of the patients based on their the specifics of their diseases, in terms of maybe a patient is more susceptible to a specific disease, or once the disease is there, they might have better prognosis or worse based on the biology of the actual tumor, and depending on what kind of treatment we have available. and also they can respond to treatment very differently based on the specific characteristics of the patient or the disease. So, so what is not in the definition? We haven't heard in this definition so far of precision medicine. Anyone, what we usually hear about precision medicine? So we haven't heard of genomics. So precision medicine doesn't just mean that we're looking at the genome of the patient or the genome of the tumor and try to figure out specific treatment based on that. It also means specifics about lifestyle, diet, or the microbiome of the patient, environmental factors, the actual phenotype of the disease, obviously genotype, and maybe even specific gene expression levels at that point of the time. So if you look at this kind of setting up subpopulations based on diseases, we've been actually doing precision medicine for a long time. Even in the Middle Ages, we were able to distinguish between people who were coughing or not coughing, or later people who had diabetes or cancer. And now, as I said, we're drilling down very specifically even inside diseases. For example, in cancer, in breast cancer, if a patient is HER2 positive breast cancer or HER2 negative breast cancer. So basically what's changing over time in precision medicine is the level of precision in this classification. So now kind of the new definition of precision medicine is the ability to classify individuals into subpopulations with a higher precision than before. And that's where we see medicine going, not just in cancer, but now in diabetes and a lot of other diseases. Any questions so far about this? Okay, so one interesting subfield that kind of arises with all the genomic identification of different diseases and different patients is pharmacogenomics. So as you probably can infer from the name, it's a mix of pharmacology and genomics. So what happens actually turns out that people, based on their genomic profile, react to drugs differently. So there are different subtypes, pharmacokinetics that's mostly around how drugs absorb or distribute or how the drugs metabolize in the body, and pharmacodynamics, which is more around how the drugs actually work in terms of the biological pathways and other targets in the patient's body. So actually, this is so relevant now that FDA lists these warnings on specific drugs. So one example here is this Cyp2 D6 gene. If it has a specific variant, then it actually affects about 20-30% of the patients who would have altered metabolism for metabolizing different drugs. And you would see very common drugs here, codeine, for example. There are some other genes that affect some other very common drugs. For example, I believe one of the pain medications, ibuprofen is one of them, I think. So what happens here, for example, with codeine is codeine is a pre-drug when you get it in the bottle. So to actually turn it into a drug, your body has to metabolize it. So it actually turns to morphine when it's metabolized, and so based on the variant in this gene, your body might metabolize slower codeine than other people. So there might be some dosage differences that your physician would have to look after and some other things. So as I said, these are actually already listed on drugs. So this is one of the labels from Plavix, which tells you that if you have a certain variant, then there might be some cardiovascular events. Yeah, and if you go to this link, then there's actually a list of the drugs that are currently listed at the FDA website, and you can look them up. And there are specific tests, genomic tests, to check for these variants in these genes. So there's a long list of these drugs that are already listed here. So I actually know that Amy has one of these non-common variants for one of the drugs, and she had to look up, or there was something that she was metabolizing a drug differently than most people. Okay. Any questions about pharmacogenomics? Yes.
Well, just like in the practice of this, you know, when a doctor prescribes or whatever, I mean, what are the statistics on how often that they actually, you know, also order a correlative testing to make sure that, you know, so the action is yes or no, or do they wait for it not to be effective, or insurance companies, if they see this, do they automatically?
Yeah, I think obviously it will depend on the physician, and on the drug. So there are drugs that are, you know, that have more serious consequences. Some of them would have no effect at all on certain patients. Some of them might have very serious side effects. So those are probably the drugs that are actually tested for those variants. And I believe that for those, obviously, no, I don't think that they're going to test you for, you know, even for codeine, even though it affects 20-30% of the patients. But you know, for something more serious, like one of the chemotherapy drugs, Gleevec, for example, is one of those that is very commonly prescribed for leukemia. They're going to check for that. So I guess it depends on the drug and the seriousness of the effects that can happen.
I think it's, you know, it's great information, but I mean, how widely is it really?
Yeah, I think
a lot of people, you know, not a lot, but there's a certain percentage of people who may be getting medication that's totally not as effective as one thing.
Yeah, so I actually encourage everyone to look, you know, look on the website, and if you see a drug that you might take, then, you know, ask your doctor and see if you know, something is available to test. Probably won't hurt. I don't know how. I know that, you know, here at the cancer center, they're, you know, obviously for the more serious drugs, they're looking at these. I'm not sure if a primary care physician prescribing codeine would think about this. And obviously also, you know, I mean, that's why I think there is the continuing medical education things that these things come up. I think those. Okay. Anything else? So just moving forward. some other biomarkers that are not necessarily around pharmacogenomics and that are used in precision medicine. You know, I mentioned EGFR for lung cancer, for example. So some other, I think there was HER2 somewhere now, maybe. But also, here's Gleevec that I mentioned for myeloid leukemia. But also in other diseases, so you would see, for example, the cystic fibrosis, which is a very serious disease, as you probably know. There are drugs that are specific to certain variants of certain genes. So I guess that's a step forward that now we're looking at the genomics of cystic fibrosis patients as well. But also there are some in diabetes and heart disease and other even alcohol use or disuse disorders. There are some gene variant specific treatments. So I'm going to give you guys a couple of examples. One that I already mentioned, in breast cancer, physicians usually test for ER, PR, and HER2. These are biomarkers that have been actually used for some time now. And they actually, because of the biology of the cancer cells and these biomarkers, these are giving possible treatment options for patients who are positive for these. Unfortunately, the worst outcome is usually for the patients who are triple negative, so who are negative for all these three biomarkers, because as I said, most treatments are linked to somehow targeting these biomarkers or the biology around these biomarkers. If the patient is triple negative, then there is no target to attack. So ER stands for estrogen receptor. So the patient can be positive or negative for estrogen receptor. And PR is a progesterone receptor, positive or negative. What happens is the cancer cells themselves have these receptors, estrogen or progesterone receptors. So if the cancer cells have these receptors, then we might be able to send some signals to these cancer cells through these receptors that can affect. So affect growth of them. So actually, about 2/3 of the breast cancers are either or both of these ER, PR, or both positive. So what we can do, so we can actually lower the amount of estrogen or progesterone around the cancer cells, so they won't grow that fast. We can also block the through different biological pathways to block estrogen and progesterone to actually have effect on the growth. But unfortunately, if the cancer cell itself is negative for these two, then hormone therapy just won't work. So there is no reason to even try. The third of these is HER2, which stands for human epidermal growth factor receptor 2. So if it's positive, then there's a protein, the HER2 protein, that is overexpressed, and it leads to uncontrolled growth. So again, since this HER2 receptor is there on the cancer cell, we can target and we can find the cancer cells based on this receptor, and we can block, for example, the ability of the cancer cells to get chemical signals through this that would make the cells grow. There are specific drugs for this, or we can also block certain proteins that creates this growth. Again, if the real problem is that when, say for breast cancer, when all these three are negative, then there is no actual target on the cancer cell. Any questions around there? So a next big thing in precision medicine and immunotherapy, you guys probably heard about this. Jimmy Carter got treated with an immunotherapy treatment when he had his brain cancer, and he recovered. I thought I found this video, and I would like to show you guys. I think it explains things better than I would.
First step.
Oh, the first one. Thank you. Okay. So that was it. We had a...
That would be more considered personalized medicine.
Yes, yeah. That would be. Bill, did you check that someone?
They were saying they weren't seeing any video. Just got one minute ago, and they weren't seeing that video.
Well, they actually, I think Amy sent out the slides, and so the video is in the slides, so they can watch it. You guys can watch it. Okay. So what's happening actually here? We know that the immune system is actually able to detect and destroy abnormal cells, including cancer cells. It's actually happening in all of our bodies. That's why, not everyone has cancer, because when a mutation happens, usually, and a cell starts acting up, then can they see it now?
I just texted them what you said, just in case.
So when
I'm seeing your presentation right now.
They don't?
I'm seeing your presentation.
Oh, okay. So when a cell starts behaving badly, then and that happens in all of our bodies daily. Then immune cells are recognizing those cells and just destroy them. When things go bad with cancer cells, is that actually cancer cells are able to fight back against the immune cells. So they create all kinds of defensive mechanisms. So they would make cells around them signal, so immune cells would not find them, and they would create chemicals that would disorient the immune system. So there are just many things that cancer cells do to not be recognized. And also, there are what researchers are saying, that usually there is at least some immune cells that would still recognize some of the cancer cells. They're just not enough and not strong enough to fight them. So what we're trying to do is to stimulate the activities of these specific immune cells that are able to find the cancer cells. And also, researchers are creating, using actually gene technology to create, modify these immune cells and make them make it possible for them to find the cancer cells. So what this one specific, and there are multiple of these, I'm not going to go into details with all of them. This CAR T cell therapy is there are actually FDA approved treatments currently, and drug companies are pouring millions into these, actually building these factories that would produce these large number of T cells. So what happens here is T cells are collected from the patient, and then they genetically modify these T cells specifically to the patient's tumor. So they make the T cells able to recognize that specific tumor that the patient actually has in his or her body. And then once they did that, they grow and multiply these T cells to the billions. In the video, you saw all those jars with with that liquid, those were basically the T cells in some solution growing. And so once they have enough of and we're talking about, a really large number, like more than a gallon of that stuff that they grow the T cells in. And then once they have enough, they actually deplete the patient's body of the existing T cells, so they pretty much kill their immune system using chemotherapy. And then the whole big batch of T cells, they just push it back into the patient and then wait. And it takes a couple of days until there's some results. As you've seen in the video, there are very positive outcomes currently. Okay, any questions or any discussion about that? I think it's really cool. It's really interesting, and it's really not old. I mean, even 5 years ago, you couldn't have gotten this treatment. Here at VC, we actually have some clinical trials going on in immunotherapy. So,
Are there any CAR-specific ones?
I think so. Yeah, so I think it's coming, and I mean, obviously, it's still very expensive because it's really personalized medicine. This is really specific to the patient, so you can't just put out some drug that would do the same thing for everyone. You have to manufacture these T cells specifically for that specific patient. So it's still very expensive, but it's a very promising treatment, I think. Okay. So next big thing, organoids. This was actually last year, I think NIH picked this as the something of the year. This was a big new discovery or new option that people are starting to do. So what they do with organoids, they grow kind of small model organs from stem cells. So they take the patient's stem cells, and then they have the ways to make it differentiate into specific organs. So let's say they grow small bowel cells, and obviously it's not going to grow, a piece of bowel in the petri dish. Though that's actually one promising, development down the line for regenerative medicine and organ transplant. But in this context, what we're talking about, they are just creating enough structure that is similar enough to the real organs, so they can do things with it. So specifically for cancer, they use it for modeling the disease. So they would grow, let's say, a piece of pancreas of the patient out of the patient's stem cells, and then introduce mutations specific to the patient's cancer, and then one example of how they use it, they actually test treatments on that specific cancer that is identical to the patient's cancer. So they would see which treatment works the best. But they also use this kind of mechanism to find the cancer driving mutations. Because what happens in cancer, cancer is basically a genetic disease. You would have mutations in your cells, and then the cell would just go crazy. And there are a lot of mutations. There might be thousands of mutations, somatic mutations in that specific cancer cell, but not all of them are driver mutations. There are probably a couple or a handful or maybe a couple of hundred that are considered driver mutations. The rest of it is kind of just accidental passenger mutations. But what they can do with this, once they created these organoid structures, they can introduce selectively the mutations into these organoids. So they could look which mutations actually cause cancer in those organoids. So again, this is a very new thing, very interesting and very promising. I heard that there are actually companies that are starting to do this for treatment as well. I don't think that insurance would pay for this, so this is probably for the top 0.1% who could pay for.
How is this different than taking out like laryngeal tumor and growing up like a new mouse? Where you can grow the tumor itself.
Yeah, so I think
I guess that's that kind of not this, but you can kind of do that. In the past in a different way.
So I think how this is different is this is more controlled. They can, when you take out a piece of tumor, you don't exactly know what's in there. But if you start from stem cells and you start from non-cancerous, and you introduce the cancer, then I think you know better. But they also say it's faster, so you don't have to wait, because if we're talking about the treatment of a patient,
right.
This needs to happen maybe in a month, the whole process. Because otherwise, if you wait for putting a PDX in a mouse and then grow it and then harvest and analyze, that might be different. I don't know. I don't exactly know all the details, but it's a very promising. So what I heard, there's this one company I'm going to talk about it a little later. They can do a turnover of this whole growing and checking treatments in about a week. So that is a big step up, I think. Yeah. Any more question?
The chemo share from UVA does this, right?
I don't know.
No, they devised a separate instrument that's called HemoShare.
Mm-hmm.
So they enrich the cells whatever they want to be injected to the patients for organ transplantation and other those stuffs. Those are very specific.
Could be. So are you talking about what kind of transplant?
You know the UVA, right? They
Yeah.
have a lot of transplantations for kids and other patients.
Pancreatic? Or
I hope so.
Yeah, I think that's a little different. What they do is, I don't think they do organoids. They harvest so the interesting thing with pancreatic transplant is they don't actually transplant the whole pancreas. They harvest just cells from the pancreas and they inject it into the liver. And those cells will live in the liver and kind of do the same thing, probably not as effective as if there was a whole pancreas, but I think they do that. There were discussions here at VCU as well. My wife is actually a pediatric GI physician here, and so she has been involved in those discussions, but I think VCU just didn't have enough support for not actually doing the surgery, but after the whole support network that they would need.
Even in Dr. Rosenberg's study, so he was not able to cure 67, but on his 68th patient, he injected more doses.
Yeah.
So how come this is going to be specific rather than dose specific?
Yeah, I don't know. I mean, that was, I guess, at the very beginning in the 80s. So hopefully they have, better knowledge of, what number of T cells you need to be enough to do. And I mean, this is still obviously not 100% of the time work. So it's, with cancer, pretty much what you can get is maybe better hope to get treated. And these treatments, they're not going to start with this treatment at the first line of treatment. They're still going to do the regular chemotherapy or maybe the other precision medicine type of drugs, and they would probably go to this treatment when the first and maybe the second and the third lines of treatment failed, and there's nothing else to do. I don't think we're there yet that oh, this is available and everyone who has pancreatic cancer or something like that would get it and would be healed. That would be great, but fortunately I don't think we're there yet.
Because they had, I don't know if you've seen the First in Human series. I want to say movie, but
Little videos.
They're like an hour and a half video. I think it came out of Discovery. One of the, and it's all about MCI or NIH and first in line in human. And one of them is I believe it's called T therapy on this individual and kind of how that occurred and what this patient's response and it didn't go great, kind of thing. But that's a really interesting thing.
So, but in the pharmacy realms, this is really hot. So there are. Last week I was asked how much I knew about CAR-T and if I wanted to go to a pharmacy company to work, because they are trying to find. I mean, this is really hot. I mean, people are trying to grow this and the whole industry is trying to go after it. So we'll see. Okay, so the last thing that I wanted to talk to you guys, and I think you're going to hear more about the genomics data comments from Amy. Is there a question, Bill?
Yeah, how is Alex taking attendance today for the web? Oh, Amy, she has a listing. It does it automatically.
Okay. So real world evidence is a big thing at NIH currently. So what they're trying to do is okay, so let's step back a little. So, about 10 years ago, all larger hospitals switched to electronic data, medical records. So now we collect all this data, right? So everything is in electronic format and we have access to it, and it would be great to use it. So what NIH is saying that now that we have all this data, why don't we try to look at that data and see, what happens in real life with patients who have certain type of cancer, for example, and get certain type of treatment. So instead of doing these very expensive and very limited clinical trials where you might have 5 patients in a treatment group, why don't we try to combine a lot of data and see if the 2 million women who had breast cancer and this type of breast cancer, what kind of treatment they got and what outcome they got at the end. So obviously to do that, we need to have access to the data. We need to be able to combine these large data sets and need to be able to analyze the data. And so there are, these, what I listed here, these are kind of things that people are trying to go. The first one is the genomic data commons. I think Amy is going to talk about that later, so I'm not going there. Another one is the Orion network, which is I think about 20 institutions who got together and agreed to share data on patients who have genomic data together with clinical data. So they created this large data set, and now they can go and see what kind of patients they have there. And so if someone has a patient whose genomic profile is similar to a number of patients in the database, then they can compare the outcomes for a specific treatment. The third one is a similar, the Genie project. I'm actually trying to get into that specific consortium. VCU, so again, very similar concept, sharing a large amount of patient data, who also have genomic data available and look at predictors and outcomes and all that. And then Tempus is an interesting. This is actually a private company out of Chicago. The story behind is that the guy, the founder of Groupon, who's a billionaire, his wife had breast cancer, and they were going through treatment and all the whole process at University of Chicago, and he realized that even though University of Chicago is not a bad university, they didn't have a good way to handle all the data related to cancer. So he poured about $1 billion into his company, created a industry-level sequencing facility and the path lab and everything. So their main profile is they also rated Northwestern and the University of Chicago. They hired away 300 best people in genomics and bioinformatics and pathology and all that. And so now they are a sequencing company, so you can send samples to them and they would sequence those samples, but they also do, they are a technology company, so they siphon up all the medical data of the patient, so all the path reports, clinical notes, but also imaging, and obviously the genomics data and everything. And they have this software that is web-based. So if you're a physician and you send a sample to them, then you can go, once you have your results, you can go to this website and you would get, this is the genomic profile of a mutation profile for patient, and this is similar to, a couple of million or hundreds or whatever patients that we already have in our database, and you can compare a lot of things with treatments and outcomes and make a educated decision about what might work for that specific patient. So I think this is great, and it's interesting that this kind of decision support is not coming out of a university, which usually happens with these new things, but it's coming out from a private company. And
what about all the patient, HIPAA? I'm assuming it's all de-identified.
So they are. So I mean, we're
say I don't want my data to go to a private company for them.
I mean, your data, even if you just do a hemoglobin or whatever, your data is going to LabCorp. What's the difference? So it's the same way.
You're using it in a very different way, though.
So this is.
And it's a for-profit company.
Yes, but LabCorp is a for-profit company.
Right, but they're not using it.
They are actually, so what happens there is they are actually a covered entity in terms of HIPAA, because they're doing treatment, they're doing clinical treatment by doing the test, the clinical testing for genomics. So there is no, in terms of HIPAA and in terms of privacy, there is no difference between LabCorp and.
But is LabCorp, like you send in the CBC, they're sending you a result.
Yeah.
Are they collecting all the ancillary data with that patient?
Well, they collect your social security number and
No,
your
but I'm
name
talking
and
about,
everything.
like you said, all your imaging, all your history.
Well,
all your
but
notes,
how about an HIV testing? It's just as sensitive, right? So
yeah, but there's laws and legalities around the HIV test.
Yeah, but it's same. There's. Okay.
But I mean, I think there is a huge ethical problem because your genome can't be de-identified. Now
Right.
you can do all kinds of jiggery-pokery with a computer system to make it harder for people to figure out who you are, but I don't trust that. I mean, I wouldn't send for one of those like home genetic tests, 23andMe kinds of things, because you're signing away all kinds of privacy rights with that, and I don't trust LabCorp with that kind of.
So I think
I think
it's
just-
no, I
think
understand,
there's
and
a lot of
it's an
questions
interest. Yes, it's an
about it,
interesting
yeah.
question, and I think the problem around this is actually and I'm a foreigner, so I can say this, but it's a problem with the U.S. society, with all the how you get insurance or not get, and how this might affect your job certificates, all that thing. In Europe, everything, for example, in Great Britain, all of this is already going to one place because that's how things work. There is one health system. If they do genomics on you, it's collected at one place, and they can do great research. They have much more data just in the UK than we have in all these separate small little entities, because they have population-based data there. So it's just, again, I understand all the questions, and it's always a balancing act of what's important, the individual or the greater good. Okay, thank you. I think that's all for me.